For Aging Issues in Aging seminar. This is our monthly event, and I'm very pleased to have one of our newest faculty members at WashU with us. As you can see, Dr. Washington's title, her new title as of 1 month ago, is Associate Professor, Washington University in St. Louis Division of Palliative Medicine. Karla comes to us from the med school at the University of Missouri in Columbia, where she also got her PhD. And I had the privilege of working with Dr. Washington several years ago. She had been selected as a John A. Hartford faculty scholar in social work, recognizing her promise as a researcher. And Karla is interested in the psychosocial wellness of older people, of all people really, with serious illnesses such as cancer, dementia, and neuromuscular disorders like ALS. She's particularly interested in caregivers, and she is going to tell us today about her work in geriatric palliative care, and also say a bit about the Division of Palliative Medicine's initiatives in this area that she's been brought on to help build. So thank you so much, Karla, for being here with us, and we look forward to your talk.
Thank you so much. And I was looking back through some of my notes and was reminded, you may not remember, but I first met Nancy Morrill Howell in 2006. Oh, wow. I was transferring all of my old files to my new computer, and we met in an airport, and I was so impressed and had the opportunity. We were all headed to the Gerontological Society of America conference, and I wish I could remember where. It's possibly Dallas. I remember being on a treadmill and someone had said that I smelled like I was sweating beef. And to me, that just screams Dallas. But those are the early days. And I have been so honored to be in your circle of colleagues and have watched with great excitement all of the exciting work that's coming out of the Center on Aging here at Washington University. And I'm super excited to get to spend some time with everyone today. As Nancy mentioned, I am less than 2 months on the new job, and I am already on the naughty list, I think, with the most delightful tech support people I've ever met in my entire life. But I think we are all set as far as technology goes. But if at some point anything goes awry, just let me know and I will do my best to try and fix it. It is undoubtedly user error on my part. So as Nancy mentioned, I wanted to talk a little bit today about building an evidence base for psychosocial intervention in geriatric palliative care. Have sort of 3 objectives, and if you are a geriatrician or a palliative care specialist, please don't be disappointed in the first objective because we won't spend a tremendous amount of time on it. But I wanted to start by first just defining geriatric palliative care for those who are less familiar, so we all have some sort of shared meaning around these concepts. And I thought we could move forward and briefly review and examine the strength of the evidence base for psychosocial intervention in geriatric palliative care. And then finally, and I hope this comprises much of our time together today, really thinking about a future for psychosocial intervention research in geriatric palliative care. Here at Washington University specifically, as Nancy mentioned, I've been brought on as part of a team that's been given quite a task to really move into some national and international leadership in this space. And we're certainly really excited to do so, especially with some of the amazing, talented people. I was reminded this morning in an email with Dr. Brian Carpenter that he is a part of our division as well. And so we obviously have all of the right ingredients to continue moving forward here at Washington University and then certainly beyond as well. So this slide is really meant, again, to get at that first objective, distinguishing among related but very different in some respects types of care. So we'll have another slide where we look specifically at some definitions, but I wanted this sort of large and in charge right out of the gate so that we can just introduce the idea that palliative care, hospice care, end-of-life care, and geriatric care are all related, but they are distinct concepts. And in terms of a definition, I thought it might be best to really orient ourselves to one of the types of care. And so since I spend a lot of time in the palliative care space, I thought we could use that as our frame of reference. So I'll start by defining palliative care by saying it's the prevention and relief of physical, psychological, social, and spiritual suffering of individuals and families facing serious or life-threatening illness. And you'll notice that there's a different font color for some of the terms that I really wanted to remember to talk more about. And the first is really orienting everyone to that biopsychosocial and spiritual perspective that palliative care takes. That's certainly not unique to palliative care and palliative medicine. I will say, especially after having had the opportunity and really the honor to work with lots of different healthcare specialties, I do think palliative care centers that biopsychosocial and spiritual perspective in a way that other specialties may not always. So that's really a central tenet of the work we do. And then the second point, there's really that individuals and families, which is really important to my work. In palliative care, the patient and their family is really envisioned as the unit of care, this interdependent unit of care. And so obviously there's healthcare provided to the patient, right? That's the traditional way we do things. But there are also services provided to the families, and that really has a couple of different layers. There's certainly the layer where we support families because they tend to be caregivers. And so that's really an indirect way of enhancing patient care. But the other layer, and the layer where I focus much of my work, is really on supporting families because they have inherent dignity and worth as humans. And so much of the time in palliative care, and certainly in the research that I do, we will have outcomes that center the caregiving experience. And so looking at psychological distress, for example, among family caregivers is something that's really a common feature of the work that I do. But we have all of those different layers of intervention, and then obviously this really broad perspective of people as whole people. So palliative care is typically provided by an interdisciplinary team of healthcare providers, some people who are much smarter and more advanced in their career than I absolutely argue that we're in a transdisciplinary space. I'm trained as a social worker, so I've worked for a number of different bureaucracies and in lots of different settings. And I have to say healthcare is one of the most hierarchical systems I've ever had the opportunity of working in. So I don't see it in the healthcare space, especially when you think that different disciplines in healthcare are really licensed to do very different tasks. I don't think that we're to the point where those disciplinary boundaries have entirely really faded away or blurred. I think they're still pretty distinct in some cases, although again, lots of people who spend a lot of time in this space see that differently and really see us moving toward transdisciplinary moments. And I can certainly get on board with that. In terms of the research, so sort of the science behind palliative care, I think we're in transdisciplinary spaces more often than not. And so you have people who might be trained in psychology and pharmacy and nursing working together to really advance the science of palliative care in a way where those disciplines are blurred more often. And if, again, many people in this space see that differently. And if we have time, I'd be happy to have a conversation about that. I struggle a little, though, to say that we're in that transdisciplinary space when the science is applied. And then others argue interprofessional, and I get less salty about that. Obviously, when we're in a healthcare space providing services, the extent to which something is a discipline versus a depression, some of those more philosophical arguments are a little less relevant for me in my work. But I wanted to introduce those alternate terms just in case they are used in this space. So palliative care really focuses on quality of life and symptom management, so not on eliminating disease. However, non-hospice palliative care, so again, if you look at the image, you'll see hospice care in the United States, at least, a really important qualifier for this image. Hospice care in the United States is always a type of palliative care, right? That hospice care circle is really subsumed in the palliative care circle, and it's always end of life care in the United States. And so hospice care in the US is typically provided to individuals who have a life expectancy of 6 months or less. And it's almost exclusively provided to individuals who have an exclusively palliative approach to care. So they're not seeking what we call disease-directed treatments. Sometimes you'll hear people call them curative. We can probably have a longer discussion on some of the challenges with calling things curative that have a low likelihood of an outcome that most of the general public would acknowledge as a cure. But the overarching message here in this point is really that oftentimes people think about palliative care as being synonymous with end-of-life care, and it is absolutely not. It's a real barrier to people getting gold standard symptom management who have serious illness, who may not be or may not see themselves at an end-of-life stage. And in fact, for many different diagnostic categories, we're getting really good science on the benefit of palliative care early in a disease trajectory, oftentimes at the time of diagnosis. So palliative care and end-of-life care overlap, right? Not exclusively. We have palliative care that's not end-of-life care. And then we have end-of-life care that's not typically palliative in nature, that's not particularly palliative at all, really focused on that disease-directed treatment. So they're not synonymous. And people with serious illness of really all stages of disease progression and also all ages can receive palliative care. And we are really blessed in the field of palliative care to have some amazing work happening in pediatrics. And it's just not a space I've spent a lot of time, so we won't spend a lot of time on that today, except to talk about some of the key principles and some of the interventions and psychosocial work we do, which certainly would have utility. And if we don't have a strong evidence base, I think we could at least say that there's promise there for some of those interventions. So what do we know? I mentioned we were going to review the evidence, and my goodness, if there are librarians on board, prepare to be underwhelmed. I really wanted to summarize a massive body of literature in one slide, and here's what I settled on. So seriously ill individuals and those who care for them are at increased risk for psychological distress, physical health problems, and compromised quality of life, right? That's a pretty enormous statement. So let's spend a little time on that. The first thing I want to sort of point out is a lot of people who are seriously ill and a lot of people who care for seriously ill people have joyful lives and have meaningful lives. And that's certainly the goal of palliative care interventions. So when I say people are at increased risk for outcomes like psychological stress, physical health problems, obviously if you have a serious illness, that's a physical health problem. That statement's really referring a lot to family caregivers, but also to situations like poor symptom management is probably more applicable to the patient situation, compromised quality of life. That's not an inevitable outcome. And even when we don't intervene, we see people who are on paths that we used to call resilient, and there's some discussion on whether or not resilient is the right term, and whether that unduly places the responsibility for well-being on the individual when we have some structural issues that we need to target to really promote wellness to the degree that we can. But we see people who do well, and that's one of the gaps, and we'll talk more about gaps in a second, is that we probably as a field haven't fully learned as much as we can from examining paths of well-being. So it's definitely an opportunity. But we do see this increased risk, and so it obviously varies on lots of different variables. However, I was writing a grant proposal and looking at psychological distress, anxiety specifically, among cancer family caregivers, and the elevated risk of experiencing clinically significant anxiety was 6 times that of the general population. So we do see increased risk. The other place where this has gotten a bit muddy is when we look at things like morbidity and mortality, and when we do coarse research, which is sometimes needed, especially in a field that's growing really very much in the early stages of development like ours is. There have been early studies, for example, that suggest family caregiving increases risk of mortality. When we do additional research, we learn that those are for specific groups, people who experience caregiving as strain, involving a lot of strain, older caregivers. There's also studies that suggest caregiving is in no way related to mortality. And then you look at the data and you see, oh, well, but the people who were entering caregiving roles were healthy to begin with. And was that why they were selected? So there's a lot of noise that we're still unpacking. So there is still descriptive work to be done in this space, and there's still real value in that description. However, as we sort of shake that Polaroid image, it seems pretty clear that we can say that there is increased risk for poor outcomes. However, we also know we can do things to improve the experience of serious illness and its outcomes. I think I have not perfected, I have improved my ability to engage in the art of defensive grant writing. So I think I've addressed this. I haven't received this feedback from grant reviewers in some time, but early on when I was still trying to find my footing in this space, I would get responses from grant reviewers in particular who would say things like, well, if you're caring for someone who's dying, doesn't it make sense that you would be sad? Doesn't it make sense, or make sense rather, that you would be worried? And of course it does. And I'm not into pathologizing human experience. It's just not my thing. But what is really clear, and what certainly my research team and many others in this field have been able to demonstrate, though, is there are absolutely very practical, tangible, in some cases scalable things we can do to improve that experience and its outcome. So we have a number of different interventions, and we'll talk more specifically about some of them in a moment, but we know we can do better. And we should. And so much of my work is moving in that direction of really supporting seriously ill individuals and their families. So one example I wanted to talk about, I'll talk about 3 examples of projects that are really targeting that psychosocial wellness and serious illness care. And the first is a project I'm really excited about. We have just been able to secure some really exciting resources from some hospice foundations. I'll talk a little bit about these projects in a second, but the Hospice Foundation of the Ozarks, in addition to the Barnes Jewish Foundation, have provided some resources for us to really breathe life into an idea I've had for quite some time that grew out of my work with rural hospices across the state of Missouri. And it's always interesting to me to be in spaces where I have the opportunity in the same research project to work with major, huge hospices that are affiliated with academic medical centers and all the resources they have. And then also have participants in research from really rural hospice agencies where, for example, the hospice social worker might also be the volunteer coordinator, might also be the bereavement coordinator, might also be the quality assurance individual. And so we have different needs and have done some descriptive work, really mapping out some of the pain management challenges that rural family caregivers face when caring for someone receiving hospice. And so on the slide to the right are a couple of call out boxes from a recent grant application. The first box 1 is from a bereaved caregiver who had cared for someone who died the day after they began taking pain medications. And so that caregiver said, I always felt like I never got to say goodbye to him. This is her spouse, I believe. He was talking to me one day and the next day they started pain medication and he was gone. And that could have been a function of what was happening to him, but I think a lot of it was the morphine. So this is an individual who believed that she played a role in hastening the death, which is of her care recipient. And that's one of the barriers. We'll go through the list in a second, but this really exemplifies that. And I'm sure you can imagine what that would feel like to someone for whom that was not a desirable outcome, or perhaps someone who would have valued the opportunity to say some of those things we know are important to say as someone is nearing the end of their life. So again, I'll orient you to this as a hospice study. So those are individuals, unlike the larger group of palliative care. These are individuals who are nearing the end of life. The second box I just included in the grant application, and I wanted to share it here. I thought it was so telling. NPR, several years ago now, had done a story on what they referred to as the opioid crisis. And these are comments out of rural Missouri, or comments about rural Missouri. And so someone commented on the NPR article, we drove through Missouri last summer. It was like The Walking Dead. There were so many strung out people everywhere we stopped, right? Really speaking to the stigma associated with opioid use, addiction problems. I bet at least half of those people who got prescription opioids are on heroin now. Shameful. right, for people who were prescribed opioids and took them. And I'm just saying, or rather, just because the doctor offers something doesn't mean you have to take it, you can turn it down. So there's just this, I thought, comments that really exemplified some of the stigma and challenges that people experience, probably in all communities, right? I think we can all think of communities where this would be true. One of the challenges in rural spaces, of course, is that privacy looks very different, and that people often know, for example, even if the car is unmarked, when Jill from church pulls up to your house, that means somebody's receiving hospice care. And so there are likely some pain medications on the premises, and it just introduces a number of different challenges. And some of the ones we've identified and our team's work in these have been repeated time and time again, to the point where we maybe can stop with the descriptive work actually around barriers to pain management. But we have concerns rather about medication, addiction, tolerance, side effects, and again, from box 1 example, hastening death. And then some life experiences and values factor in here. And again, some of these are different depending on community type and individual life experiences, but we see stoicism. Certainly that toughness is something that we see in rural spaces. And I won't spend a lot of time on examples, but I'm in the middle of interviews with people in rural communities about pain. And I was on the phone the other day with someone, and I, he hadn't yet, we were nearing the end of the interview, so I thought I could be a little bit more directive and, or rather at least steer the conversation to some topics we hadn't get hit on. And we talked about toughness, and he said, oh, that doesn't resonate with me. I don't feel the need to be tough. And so we talked a little bit about what that meant. And I got the transcript back and had forgotten. He actually had been on a 4-wheeler and had a head injury, and his head was somehow swelling. He just mentioned that it was the first time he could see his face without using a mirror. And then I had said, oh, what did they say at the hospital? And he said, oh, I just walked it off. And I just thought, wow, you might not identify that as toughness, right? Because people don't always see culture or think about it in those ways. But I just thought, wow, I definitely, if my head was swelling to where I could see my face without a mirror, I for sure would have gone to the hospital. And so I think obviously the way we think about things is shaped by our life experiences, and there could be lots of layers there. That's my new favorite example of stoicism, as he said, I just walked it off. This notion of being self-sufficient, not wanting to be a bother, fatalism, not really believing that pain management can be controlled, stigma, certainly we have lots of examples of that in box 2. And then the final point here is really sometimes the absence or barriers to patient and family-centered care. I think many people enter palliative care because they're very passionate about pain and symptom management, and they really want people to have a peaceful experience. And so sometimes in our zeal for peace and to support people, I think sometimes we don't hear some of the barriers or don't really validate those experiences, and instead try to sort of force an agenda around pain and symptom management. And that typically goes poorly. For those of you who have a clinical component to your practice, you will not be surprised to learn pushing your agenda on another person typically doesn't go well. And it especially is a poor fit for individuals in rural communities for a number of different reasons. So we have some work in this space. I mentioned we were incredibly fortunate to have generous support of a couple of key foundations, because what we don't know in this space and what we hope to pursue in future research is really how can we implement evidence-based interventions to address identified barriers to pain management. We have an evidence-informed intervention, and certainly it's been subjected to RCTs in different settings, so we can almost say evidence-based. We're finishing up some of that work with some of our preliminary work. Implementation is a very unique beast. And one of the reasons why, when I was looking back at my pros and cons list for transitioning to Washington University, certainly a gem in the crown of WashU is the work that's being done in implementation science. And so I have an ulterior motive to my presentation today. One is very much connecting with a broader WashU community. So please know that that certainly for me and for my colleagues in the Division of Palliative Medicine, we have a number of different problems that get solved through a D&I lens. and we're interested in moving that forward. A next area of research is really strengthening collaboration in hospice team meetings. So again, for this example, we're still in that hospice space. And hospices are required by federal regulations to build teams that include at least nurses, physicians, social workers, and a spiritual counselor of some kind. So those are the 4 required pieces. Most also involve specialized people in bereavement. There are pharmacists involved, different therapists, volunteer coordinators, volunteers at times, home health aides, lots of people that make up these interdisciplinary teams that are required again by federal regulations to meet every couple of weeks to talk about each and every patient that they are caring for. And when I entered my doctoral program, my first exposure to research in this space in 2005 or 6 was to sit in on these hospice team meetings. So at this point, I've seen thousands. And I'm not a meeting person generally, so they're always a little tricky for me. But my goodness, these have always been situations that are really ripe for great interdisciplinary collaboration. You can feel the potential in the air. And at times that air just gets sucked right out of the room. So there are a number of different challenges with meetings. And some agencies have figured this out. And so these vary based on the degree to which they're present in different team meetings. Over time, and I need to label this as really anecdotal. I mentioned I've watched these for a number of years. It certainly seems to me that there's a significant increase in the number of patients and families whose care is discussed in any team meeting. And so I remember in 2005, 2006, sitting in on meetings, they would last a couple of hours and we would maybe talk about 30, 40 patients. It's not uncommon to at this point talk about many more than 100 patients in that same sort of 2 or 3 hour time frame. So there's really a lot of patient care that's being discussed, which would be really difficult to manage even a really well-functioning team. At times, hospice teams can lack up-to-date information from patients and families. They typically have, keep in mind, some of the rural hospices in the state of Missouri still don't have electronic medical records in 2021. So you're dealing with paper copies, which introduces another layer of challenge to the equation. But even at times when you have an electronic medical record, hospice agencies are usually in the home. So they are conducting home visits rather a few times a week. So information is just as recent or as current as it's been entered into the system. And so, for example, it's been a few days since a hospice nurse, for example, has visited a patient and their family in the home. Then the data that people are using to make care plan decisions are really already a few days old at that time. There are barriers to patient and family participation. One of my colleagues who is also now in the WashU Division of Palliative Medicine, Debbie Parker Oliver, has done a tremendous amount of work over a number of years to involve patients and families in team meetings and shown really great results when we can make it happen. But it's again, one of these implementation challenges, because if you're going to talk about 110 patients and you have 3 hours to do that, really preparing a patient, if the patient's able, or more commonly a family caregiver, to participate in those meetings is pretty labor intensive because they are quick, and patients and families often have a lot to share and really need to be meaningfully prepared for those team meetings. And really, if you think about the potentially stressful environment family caregivers are operating in, some of that need for education, some of the need for emotional support, which they would typically get in a home visit, right? That's the way they usually would interact with their healthcare team. It's just very different than this very fast-paced clinical setting of a team meeting. So we see lots of barriers to patient and family participation, and it's still certainly the exception rather than the norm. And the meetings can have a predominant regulatory or biomedical focus. And so the regulatory really piece is complicated and really interesting, probably to those with an administrative lens, and maybe not many others, except for to say that patients have to meet criteria to continue to receive hospice services, and that can be really involved, and it's very important to ensure services to make sure that they continue to meet those criteria. And so as hospice agencies have wanted to ensure the continued care for patients. Sometimes those meetings really become a lot about who's being recertified, do they still meet criteria, and making sure that they're still appropriate for services. But at times when we talk to people who are in those meetings, that feels a little less about ensuring quality care, and it really becomes a lot about, are we satisfying third parties who might come and look at this and question that. And then there's a biomedical focus, which can be really easy to do right in a healthcare setting. We talked earlier about that biopsychosocial and spiritual perspective that hospice teams really like to have and aspire to have. But when you're moving quickly and someone's pain medication isn't working, it's not uncommon at all for that to take priority over the fact that they're having significant family conflict or financial difficulties. The other thing that I want to say, and we can spend some time talking about it, but just in case it's tripping anyone up, I do want to acknowledge, again, with that biopsychosocial and spiritual framework, that there are very few experiences in serious illness that don't have all of those components. And so when we talk about, for example, pain, and I mentioned just now that really had a biomedical focus, of course, there are lots of psychological pieces to pain, social, functional pieces to pain. So I don't mean to suggest that any one of those experiences is exclusively biomedical in nature. But when you only have a few minutes to talk about someone's entire care plan, those discussions can really drift in that direction, which can be really challenging, especially for people who are on the team, given, for example, a specific psychosocial or spiritual emphasis. And interprofessional communication challenges is always interesting to me. I mentioned, I hope at least, that I was trained as a social worker. So it's humbling, I guess I'll say. That might be the most generous way to talk about it, to read interviews of nurses and physicians and people who are on teams with social workers and chaplains and other people who tend to communicate very differently. Social workers can talk in stories, not bullet points. And I wish I had the quotation in front of me, but I think about it every time I read a transcript from a team meeting, and there was someone, I believe it might have been a nurse, a terrific professional. They had engaged in all sorts of collaborative practices, but they said something like, I swear to God, if the social worker mentions the cat again, I'm going to scream. So really that broader context is something that some disciplines spend some more time on others. And that's certainly not to suggest that nurses and physicians don't take into account the context. They just tend to spend time on it in these interdisciplinary team meetings to a lesser degree. And so some of that really succinct, fast-paced, to the point communication is less familiar and comfortable for some individuals. And we certainly have seen disciplinary differences. And so how do you help social workers like myself, who can be a little wordy, chaplains who really like to talk about the deep guts of what it means to exist on this planet? How can you help them interact in these really fast-paced, clinically directed team meetings? And at the same time, how can you help people who, for a variety of reasons, might not initially appreciate, for example, whether or not the family caregiver is really depressed? How can you help them sort of orient themselves to that broader mission of hospice? And so we've created a tool that I'm very excited about, and we'll be moving forward in this work in the upcoming weeks. This is a very the challenge for this is going to be about informatics, and it won't surprise you now that I'm stumbling to come up with the term. This is it an alpha or beta version? This is an early version. That will be my layperson term of a dashboard that we've created, and this is a paper prototype of a tool that we've worked on for a number of years. I think I was looking before the it actually says 2016, so it's longer than I thought. It is ready to be made, and we are tapping into some resources to move forward in this work. But it's basically a tool that teams can use in that team meeting, and that can be boring and can really present a lot of challenges to interdisciplinary communication. And it really is a dashboard. So in a snapshot, what's a view of what's going on with this patient and family? And so without really going into a lot of the details, the darker colors reflect a pain that is less tolerable and more problematic for the patient. So you'll see pain, and that other is constipation symptom for this example were that really dark orange, which should tell a team in a glance, those are the two issues that we really need to tackle in this team meeting. And they're populated by data that are provided by patients if they're able, but more typically family caregivers. And so we have been successful in getting family caregivers to give us the data on a daily basis. So this is much more up to date oftentimes than information the team would otherwise have. The other piece that is very controversial, and I think we'll probably end up testing both ways, is we mentioned, or I mentioned rather at the start of this talk, that the patient and the family are the unit of care. And so we have here selected one caregiver, which is not the full caregiving team, but one individual who's also providing data about their own well-being. And we've included them in this dashboard and certainly received information from people about whether or not they like it or not. And I think we're going to move forward testing it both ways. So informatics, that's another challenge. And again, looking back at that pros and cons list, why am I so thrilled to be your colleague? I know many people at the Institute for Public Health, the Center on Aging, across the WashU campus really have that informatics expertise that is going to help us take ideas like this and really move them forward. And we'll end up with digital health solutions that facilitate that collaboration and patient and family-centered care. And it's really an exciting space to be in. I'm going to move a little bit more quickly in the interest of time for a variety of reasons, one of which is I don't have a lot to say about this final project yet. And I'll talk about that in a second. We are what a visual. I will share with you. So I have an R01 that is within the funding line at the National Cancer Institute. And in 3 short days, council will meet and decide the fate of this grant. It looks pretty good, but I think we all know horror stories. So in some respects, I was not thinking about sharing these thoughts with you in this moment whenever I selected this image, but it's actually very telling. I was looking at my browser history and NCI funding line was just right at the top. So that's certainly on our mind. But so we know, again, that there's a high prevalence of clinically significant anxiety and depression among cancer family caregivers specifically, and have really been working with people in this outpatient palliative care space. So not hospice, right? So that broader circle of palliative care, but in an outpatient clinic as opposed to an inpatient setting. We really are seeing tremendous growth in that space, and that probably will evolve over time and look different depending on the place where practice is occurring. But we're seeing growth in that space and really a need for an evidence base for psychosocial support and outpatient palliative care. We mentioned hospice, of course, has those regulations and people who have to be part of the team. What palliative care looks like in place A versus place B can be dramatically different. And I think the extent to which we can provide an evidence base so people can make decisions on the composition of palliative care teams, the more we're able to do that, the better. And so problem-solving therapy, which I have done since my very early days as a psychiatric social worker, is decades old. We have a lot of evidence on it in many, many different settings. We have shown through an R21 through the National Cancer Institute a few years ago that it's a very feasible, promising approach in outpatient palliative care. But again, we are looking forward to, fingers crossed, knock wood, light a candle, whatever you do, looking forward to potentially moving that in a positive direction in the upcoming months. And again, to be successful, we really need those large-scale multi-site studies with diverse samples. And so how can we meaningfully engage key stakeholders in behavioral intervention research that advances geriatric palliative care? I want to wrap up so we have time for Q&A, but before I leave, I'm sure there are other people in the time of COVID. What it means to be new is that that time when everyone would get together and tell you everything that's going on in the division is going to happen a little later than it ordinarily would. So if people are aware of other exciting projects in the space, please, when we get to Q&A, let me know about them. I would love to know. And also I want everyone else who tuned in today because they have an interest in geriatric palliative care to know about them. Nancy mentioned in her introductory comments that the Division of Palliative Medicine has made some really strategic moves in research space and has for years been so honored and energized by the work that's happening across campus and many people that are affiliated with the division. have been doing excellent research for years. And building on that tremendous history, the Division of Palliative Medicine has brought on a number of faculty, myself included, to focus really specifically on research in this space. So I wanted to let you know, as a representative of the Division of Palliative Medicine newbies, some of the exciting work we have that's forthcoming and that's ongoing. And we really welcome students, fellows, faculty at any stage who might have an interest in helping move these ideas forward. We have data we feel like we're drowning in more often than not. Very, very excited to collaborate with any learners you might have. So please know that, again, an ulterior motive I have in speaking with you today is really to make those connections. So I welcome them. I mentioned, again, this is an anticipated, not an actual project, this first National Cancer Institute R01, which would again test that problem-solving therapy intervention for cancer caregivers, working with some collaborators across the country to do a multi-site trial. In terms of ongoing work that we already have in action, we have a grant that's out of the National Institute on Aging, and it tests the narrative intervention for family caregivers of Alzheimer's disease and other dementias, and that's still in the very early stages. So if you're interested in that work, please let me know and I'll connect you with the appropriate folks on that project. Our National Cancer Institute R01, that's headed by Debbie Parker Oliver, again, who's now on our faculty here at WashU, is wrapping up a project we call Access. So Access for Cancer Caregivers to Education and Support for Shared Decision-Making. That's a project where individuals join those interdisciplinary team meetings, but are prepared to do so through some work we're doing in online support groups. And my goodness, the short version is that the energy and interest in online support groups from the beginning of the project, so 2017 to today, wow, that change is overwhelming. And so we're really certainly wish that something other than COVID could have been the reason why people got really interested in online support groups. But we have had some really good data from large studies in this space to share with the field, and are pleased to continue contributing to that science. And then I mentioned the Hospice Foundation of the Ozarks and the Foundation for Barnes-Jewish Hospital have provided us with some resources to do some feasibility testing of the pain support intervention for family caregivers I described. And I mentioned that here, even though it's in the gearing up phase of research, to use the technical term. But we really do think that has legs, and that's a project I want to see move forward. And I'm convinced increasingly so as we work with agencies across the state that we have the intervention we need. It's an implementation question. So I welcome those who have that interest and expertise to reach out, and we can connect via Zoom and maybe start making some plans for the next big project. So those are some of the things that are going on for me and for my research team. And I'm just so grateful to have had the time. This is my first WashU broad community interaction, and just really excited to get to share with you some of the things that I've been up to. And I hope this begins many, many discussions with you. I know there's tremendous talent on the call today and across the Institute and the center. So I think it's my job now to be quiet, and we can maybe have some Q&A. And at some point I need to stop sharing my slides, Natalie, so you can share yours. Would now be a good time to do that?
Yep, that'd be great.
Okay, here goes the stop share. Okay.
Great. Well, we have some time for questions. I was looking at the list of people that were on the call, Karla, and some people I trust that you will be meeting soon, that work in geriatrics, that work in patient services of all kinds. So I want to see, I don't think there's any questions in the chat room, unless I'm wrong, Natalie.
No, not yet. It doesn't look like.
Okay, so people can, there's not that many of us. If people want to come off mute and ask a question to Karla.
Actually, I just enabled the raise hand feature. So if you want to raise your hand, I'll unmute you.
Oh, cool. So Emily, you're going to keep track of that?
Yes.
Okay. while people are doing that, Karla, this is such a boring question.
I doubt it.
And it's, you know, what you're saying, all the people are worried about the administrative stuff, but could you please educate this group on the struggles with who pays for palliative versus?
So, yes. And so the struggle I mentioned from an administrative perspective, the short version is if the question, the answer to that question is different from a hospice versus palliative care piece. The hospice, so again, that very specific tiny, not tiny, but relatively small circle, that relatively small piece of palliative care is paid for typically for people who have Medicare with a Medicare hospice benefit. It's been around since the 80s. But in order to do so, and this is where I think I mentioned this in the context of those team meetings, that's where things get really tricky. Or where things get relatively tricky. It's an invitation for people to be really mindful of whether patients continue to be eligible, but much of that money comes from Medicare. From a palliative care perspective, that's a much more complicated piece of things. Where does the palliative care take place? Is it in the hospital? Is it in the home setting? Is it through a home care agency? Most, certainly Medicare and most private insurances will have coverage. However, it's not unheard of that some of the private packages may not have sufficient coverage. In fact, and it wasn't anywhere near locally, but we were working with a hospice agency and their employees. We were talking about sort of job satisfaction and burnout. And one of the things that, again, not anywhere near where we're working now, but one of the agencies said, oh, you know, we have really terrible health insurance. And so, well, tell me more about that. And they said, we actually don't have hospice coverage, and I work for a hospice agency. So it's not unheard of that is the case. And somebody who's been in this space more recently than I, thinking about payment, can correct me if I'm wrong, because it's possible some of the policy changes that have been made more recently have ensured, for example, universal coverage. But certainly more recently, most people who would have access to sort of standard packages of healthcare would have some coverage from that piece of things. The piece that gets really tricky, that I understand just poorly enough to be dangerous in the implementation space, is, and it's why I always, in post-COVID, I fully intend to bring baked goods to someone in the billing department, or someone at a really high level who can speak to some of the challenges. For example, if you see provider X on the same day that you see the palliative care team, who can bill and how and why. So those are really the pieces that for years have been less important to me, doing those RCTs of the behavioral interventions, really trying to establish an evidence base, but have become increasingly important as you're on your third RCT, year 8 of an intervention that's very clearly evidence-based, that still isn't making it into clinical practice and identifying those barriers. And so those are pieces where things like, oh, I don't care how it gets paid, I'm an idealist, we should have the best science available. Those days, I think, are really in the past for those of us who want to see the interventions we've worked so hard to develop and test get into practice. So all of those nuances become really important. And again, I know just enough to be dangerous, aside from the hospice space. But those are the answers that we absolutely have to have as we move to implementation, because they can be real barriers. I think even thinking about the problem-solving therapy intervention, for example. So I mentioned I was trained as a social worker, and in social work, medical social services are a covered portion of what people think kind of comes along with being in the hospital, for example. Nobody expects to get billed separately for those services. And so as we move into clinics that are affiliated with academic health services, that gets really tricky, and who can and can't bill and why. And one of the things that's really exciting, and that I would really welcome conversations with people at the Center on Aging in the Institute is, I think we're certainly at an institution and that there's good synergy around shaping policies to make them make more sense for patients and families. And so oftentimes we'll talk to clinicians, for example, and they will say things like, well, we can't bill in the clinic because we're hospital affiliated. Well, someone created that policy, and someone can change that policy. And it's going to be those interdisciplinary collaborations that I know your center fosters that are going to allow us to do those pieces. It's very interesting to to introduce that possibility. It's one of my favorite conversations we always ask when we talk to clinicians in hospice and palliative care is the policy question, because I think many times they're very busy and just being really expert in their clinical practice and don't see those possibilities. But we asked, for example, a paper I wrote with a couple of palliative care fellows, we asked, if you could change one policy, what would you change, right? Just a really open-ended question. And just even opening the door to that possibility, it was the richest part of the interview by far. And so I think it's not how we usually think for those of us who are sort of clinically informed researchers. We don't immediately think of those policy implications. I think it's to the detriment of the field and why it's so exciting to be welcomed into a community like yours here at the center.
Great, thanks. You've met Brian Carpenter.
Brian Carpenter and I have heard his name for many years. We've not met in person, but I think we will today. But yeah,
Brian had a question. Are you still there in my long list of people? There he is. You want to ask your question?
Hi, Karla.
hi. It's so nice to finally meet you. It was
You
so
too.
funny when Nancy said that.
You too. Great stuff. I'm so excited to speak with you further about some of
Likewise.
these projects. I just wondered if you have been thinking on any of these projects about cross-cultural implications. You know, we're really interested in exploring issues of equity, access in the St. Louis community, and wondered whether you had thoughts about how that might fit on any of these projects.
I have tremendous thoughts on how that might fit on these projects. The first thing I will say is that obviously there are lots of layers to this. So equity and access are issues that are challenging even in the clinical space. So for example, when we do a hospice study and we receive referrals from hospice agencies, we're sort of at the mercy of who's receiving hospice services. And we know there are significant differences, and depending on who you talk to, people are very intentional about asking whether is a difference the same as a disparity, right? And that's a more philosophical argument. So if people aren't accessing services because they don't make sense for their community, is that a difference or is it a disparity? Because oftentimes, for example, in hospice and palliative care, one of the things I used to say until someone who had a cultural difference from me really, I guess, checked me, for lack of a better word, I used to talk about the hospice philosophy of care. And someone said, well, whose philosophy is that? Who developed this philosophy? And of course, it's a very Western European philosophy of care. And in fact, is that the most helpful language in working with people? And it's something I have used for years. I'm sure I have a dozen publications that reference the hospice philosophy. And so we certainly see differences. And so addressing access in the clinical space can only help given those pieces. The difference that we see, especially in the actual research studies, in addition to just needing to identify ways to engage more meaningfully in communities, is language differences, which we've addressed in some cases by just working with people who have different languages. And sometimes if someone shares a language, they share a culture. So we're able to be in that space more meaningfully. One of the real opportunities I think we have is especially in these online support communities, where I think people are performing culture in a way, or their culture is certainly evident in online spaces. And I don't know, and I suspect, thinking about your work and the work of others, that people offer support to one another in the same ways. I think there's some cultural layers, of course, to that. So that would be a huge piece. I think the other fundamental challenge that I think exists regardless of whether we're talking about the research space or the clinical space, and thinking back to a quotation of a woman, and this was in hospice, so this is unique to end of life, but I think it probably has broader implications across healthcare. And she had, it was her mom, it was a Black woman, and her mom was receiving hospice services very late, sort of a brink of death situation. And so ideally, right, we have evidence that suggests, had hospice been introduced earlier, that there might have been benefits available to this patient and family that weren't because of the late admission. And she said, you know, when you talk to your doctor and she says there's not a treatment available that's going to slow or end your disease, you believe that she cares whether or not you live, and I don't. And I thought that was so powerful, just in terms of how we talk about those pieces, about historically, certainly, but even in the current healthcare system, the ways we send messages to individuals about who matters and who doesn't, thinking about lots of those implications recently. So I think there's some real practical nuts and bolts things. Does it make sense, right, for a group of people who are Latino, for example, in their own online support group? So we think about those things in terms of the nuts and bolts. But I think a bigger issue that's always going to be there for these serious illness contexts is that broader one on equity on a policy level, but then just in terms of how do we contribute to healthcare systems that are trustworthy? And I think we have a lot of space to grow in that area.
Thank you, Brian. Any follow-up?
Well, thanks, Karla.
Great. I didn't see any hands. Did you, Emily?
No, I don't.
Okay. I have one last comment. Karla, I guess I was a little disheartened to hear your thoughts about how far we've come or haven't come in terms of interprofessional practice.
Yes.
And I believe you.
Yeah, it's been really interesting. I don't mean to cut you off. Please continue.
No, please, no. I just observed that and felt
Yeah,
a little surprised, but curious about.
one of the things that is, and I think it probably depends on your frame of reference, but really as someone studying, I'm not sure if I would feel it even as, I think I feel it more acutely as an outsider who studies those spaces in healthcare context specifically. I suspect even we hear from clinicians that they don't experience those disciplinary or professional divisions the same way even that I see. But I was, it's been months ago, but I was standing in line, right? I have a horrific Coke Zero addiction, and I'm at the vending machine several times a day. And I was just looking at people, and whether or not their last name was used on their badge depended on their discipline, what they wore, where they park.
Yeah.
There are so many, almost, and I'm not trained as an anthropologist, so my ethnographic skills are, I can't even say rusty because they were never strong, but it dictates so much about the healthcare experience. And again, I think that there are many, many people who are very invested in interdisciplinary and interprofessional work, who are invested in that looking different. But I have a family member who works for a healthcare system in a tech position, and we had met to go vote, and then drove to work together. And because I'm a professor, I have good parking. And this was at a different institution. I understand that parking challenges abound. So please don't hear me saying I currently have good parking. But then they had to go park miles away. And that person had more experience than I and had worked in the space longer, but I had a different title. So I wore something different. I parked something different. People call me Dr. Washington. They call this person by their first name.
Yeah.
And even just thinking about how we shape committees. So I retain a license as a social worker, mostly because I feel like I worked hard. I don't use it often, but I am reluctant to give it up. And at times I've been able to provide supervision for clinical social workers when it wasn't available from other resources. And even the committees that are, and I don't think it's any one discipline necessarily controlling this space. So this particular situation, they were trying to come up with programming on the weekend. And the only people that were on the committee, you had to be a nurse to be on the committee. And they were trying to come up with, well, what should the social workers offer on the weekend? And I thought, well, you should probably have a social worker on the committee, should you not? And I think those distinctions are there. I do think, however, in talking to professionals who have been in this space who are very seasoned, there has been a significant amount of progress. I think it looks very different from how it once looked. So I don't mean to suggest that there hasn't been progress. I still, the symbols really still abound to me, and I'm reminded of them really often. I think the other thing that can be interesting is working in a medical school as a non-physician. Thinking about, physicians, for example, usually have a clinical component to their practice, so they're in both of those spaces. And when I was invited, when there's been need clinically for me to go in those spaces, it's been really interesting to look around and for example, be in a swamp area and I don't have a seat. I literally don't have a seat in these spaces, or you'll see a chair that's available. Well, that's usually, XYZ who's from this other profession usually sits there. And I just finally asked, I said, where did social workers sit here? And the answer was in like sort of the quasi cafeteria. And I just thought, wow. So in that particular setting, whether or not you got a seat depended on your disciplinary background. And I think we have a long way to go. I think we're not there yet. I am excited about though, places like the Center on Aging in terms of the science. I think we're moving into a really transdisciplinary space there, and maybe we will be
Great. Well, we're glad
paths
you're
for others.
here. We're sure glad you and your colleagues are here, and we'll
Yes.
try to help you meet more people. I'm glad you had
Yes.
to
Thanks
present
so
your
much.
work. And I hope people on the call or on the talk today will reach out to you.
Yes.
Through
Please
us,
do.
or can find
Yes.
you directly and you to them, but would like to serve as a liaison for you. So thank you very much.
Thanks for the
We're
warm
gonna
welcome.
end with next month, we have our 2020 Capello Award winner. We weren't able to recognize these folks in person because of the pandemic last spring. So finally, we're going to recognize Dr. Sarah Hartz and hear about her work, specifically with the Alzheimer's Disease Research Center, as she thinks about sharing research results with people, with persons with the disease, as well as family members. So that's next March 8th coming up. And then one more announcement I think Natalie has for us, if you have on your calendar, our virtual annual Friedman Lecture is going to be more on innovation and entrepreneurship in Aging Society. But we're accepting awards now for next year's Coppola and Friedman Award winners. So please check that out and get some names in. We're going to pick them in the next month or so. So thanks so much for being here today. Stay warm.
Thanks.
Thanks.